Hi, my name's Mark Field. I'm a cardiac surgeon and I'm here to talk about loss in heart surgery.
Welcome to The Silent Why, a podcast on a mission to find out if hope can exist in 101 different types of loss, and to hear from those who have experienced them. I'm Claire.
And I'm Chris, and in this episode, well, I'm pretty silent.
Yep, sadly Chris had to sit this one out. It turns out the diaries of journalists and heart surgeons are just really tricky to coordinate, so I was solo on this joint mission for the first time.
So in this episode, Claire meets Mark Field, a cardiac surgeon from Liverpool in the north of England, who joined her in between commitments at work to talk about operating in that very small space between life and death in surgery, especially around such a vital organ.
I connected with Mark through the Aortic Dissection Charitable Trust, and I knew this was a man I wanted to speak to when he sent me the best excuse for being late to a Zoom call ever. I received an email just after the start time had passed that simply said, "Sorry Claire, 5 minutes, trying to prevent death."
Brilliant, I might try that one myself sometime. I've already heard this conversation, and you're in for a real treat. It's so rare you hear surgeons speaking like this.
As I've said to you before, I've had some hesitancy in talking about this because mostly surgeons do not talk about these things. It's in sort of unspoken truth.
We'll hear how hard it is when one of those major operations doesn't end with a healthy recovery.
I'm not sure if it's a morbid thing, but I have a list of patients who have died, and every single one of them I can look at their names and remember every single detail about what happened.
And how surgeons control or don't control their human emotions.
The patient did die. And I remember that surgeon crying, tears rolling down his eyes. And at the time, I didn't really understand it. Why would he cry in front of the whole team? Once I became a consultant, I always regretted that because I personally have had many occasions where it's happened to me.
Mark also tells me about what it's like working with such a valuable organ in our bodies and what a privilege his job is.
Having the heart in your hand is very special every time you do it. And some hearts are beautiful, anatomically beautiful. I'm sure every cardiac surgeon will tell you every time you hold a patient's heart in your hands, you do acknowledge to yourself that it is a privilege.
And it's really surprising how little training is provided for delivering the news of a patient's death, especially when the reactions to bad news vary so widely.
You can witness the relative crumbling in front of you, sort of shouting and screaming, and people may run out of the room, and sometimes it can be quite aggressive as well. And sometimes the response is so deep and so visceral that it's almost shocking to you.
It was a real privilege to interview Mark, and I think this might be one of the best loss interviews we've ever done.
Is that because I wasn't there?
Not at all.
We did wonder if this had happened occasionally, my work being what it is, and now it has. The loss of a co-host.
Although 1 out of 53 episodes isn't really that bad.
I'm still going to grieve.
You'll get over it.
What happens to feel the feelings?
Okay, well, you crack on with that, and we'll head into the episode. Annoyingly, when we recorded this, I had a weird dry throat cough thing going on after our holiday, so probably something I got off the plane. But if you're thinking my voice sounds a bit weird, that's why. So here we go. I began by asking Mark to describe an average week.
So my name's Mark Field. I live and work in Liverpool. I'm a heart surgeon with an interest in aortic surgery. I guess my typical week starts on a Monday with a clinic. On Tuesday, I have an operating list. On Wednesday, I have a clinic. Thursday, I have another operating list. And then Friday is meetings. I also have an on-call commitment as well for emergencies.
So is it quite a tricky job to balance, like the home life, work life? It sounds like it's one of those ones that would be tricky.
Yes, it is. There is a commitment to the job and a commitment to the patients. And I guess I'm on call really 24/7. So I will get called on any day and any time, whether I'm on call or not, about my particular patients. And quite often I need to drop things and come in. And quite often that extends to holidays as well. And sometimes even when you're outside the country, you may get a call in the middle of the night because of the time differences. But yeah, it's a huge commitment. But I guess it's hugely rewarding as well. You have the opportunity to save a patient's life. And sometimes quite frequently, particularly when I was a registrar, I had I drove a bit of a jalopy, and I used to drive to work and stuck in a traffic jam, and I'd look across at the guy in his Porsche next door and think, well, that's fine. I don't know what you do, but I'm going to work and I'm going to open someone's chest, so I'm going to stop their heart and operate on them and save someone's life. And that's enough, and that's very rewarding.
I mean, I think people hear heart surgery, brain surgery, these are vital organs, like you said, huge amount of risk, life and death stuff, mistakes cost lives. So what on earth made you want to specialise in hearts?
I guess it's different for every person. I guess for me, I did some research and a PhD before going into medicine. So I was a mature student in medicine. And so the time I did research in Oxford it was all about hearts. But I always wanted to be a doctor. I was a bit of a sort of failed medic, didn't quite get the A-levels to get into medical school, went and did a degree and then the PhD. And then finally, after the third or fourth attempt, got into medical school. And then I went through medical school and kept coming back to hearts and to cardiac surgery, and the more I saw of it, the more I just think, yeah, that's what I wanted to do. I was, funnily enough, I do remember when I was a medical student listening to two orthopedic surgeons talk about cardiac surgery, and they basically said, why would anyone want to be a cardiac surgeon? Your patients die. And I guess it struck me at the time, and I didn't really understand it at the time. All I knew was that, I was interested in hearts, and I was interested in fixing things. Back in the day, you did house jobs, and your first 6 months was in medicine, 6 months in surgery. And I remember doing 6 months in healthcare of the elderly, which was difficult. It's a difficult specialty. And then my second 6 months was in urology. And I just thought I was in my element here, because it's like you have a blockage and you unblock it. And I thought, even though I was research orientated, I thought, this is great. You literally unblock things, patient gets better. It's very rewarding. It's sort of very defined. And so I thought, well, I like to unblock things. I'm interested in the heart. I'll put the two together. And despite many people telling me not to do it, I eventually found my way here.
Wow. Because the heart is, there's something romantic about the heart almost. It's got this symbolic thing for so many lovely aspects of life. It's in art, literature, love, pain. It's so integral to a lot of what we say even. But seeing an actual human heart is not something that many of us get to do in life. I suspect a lot of people wouldn't want to, but I think it must be fascinating to be so close to something that's just the centre of life. Is there something special about the heart to you in that way, or is it more just that this is a part of the body I work on and it's kind of a bit more technical?
No, it's really very special. Like, although I do it twice a week, it's every single time you open up someone's breastbone and you open up the sac, the pericardium that surrounds the heart, and you suddenly faced with a heart. It's very special. Sometimes you put your hand around the heart and have to lift it up to do various things. Because there are various bits in the operation where you pause to give fluids to protect the heart when it's stopped. And so you have 2 or 3 minutes every 20 minutes to stop. And mostly that time you just reflect. Sometimes I look at myself and, just stood around waiting for this fluid to go in. And I just think, how on earth did I get to this point? What a privileged position it is. And having the heart in your hand is very special every time you do it. And some hearts are beautiful, anatomically beautiful. You just look at the structure, because obviously we spend a lot of time learning anatomy, and you just look at them, they're absolutely beautiful. And then sometimes you look at them and they're not so beautiful. No reflection on the patient, but just, they've suffered a life's worth of things, abuses, events, and obviously those are the hearts that need fixing. But yeah, every single time, I'm sure every cardiac surgeon will tell you, every time you hold a patient's heart in your hands, you do acknowledge to yourself that it is a privilege.
Wow. I love that some of them are beautiful. What a lovely idea. I hope my heart's beautiful. I'd like to think I haven't got an ugly heart. But yeah, obviously you're handling something that could just end someone's life. I mean, you do something wrong with that, it's literally life and death. So like you said, you can't avoid patients dying. That's people's first opinion when you want to go into it. So I assume that this can happen maybe during an operation, but I know there's not just one way for a patient to die in your kind of line of work. So what are the types of things that can go wrong, the kind of circumstances where a patient might die, and at what stage does that tend to happen the most?
Yeah, I mean, that's the circumstances. I mean, for a patient and their family, it's obviously the circumstances may be quite irrelevant. I mean, obviously they've suffered a death. But I think for a surgeon and the team, the anaesthetist and the team around, because there are a group of probably 8 people involved in every heart operation. And so I think the circumstances do have an effect on how it's managed or the impact it has. Because certainly we have a group of patients who come in as elective, so that they're at home, they've been seen in the clinic, and you've agreed to do, after various discussions and consent, you've agreed to do a particular operation. You've explained to them what the risks are, and then that patient comes in from home relatively well. Usually, some patients have no symptoms at all, yet they're having a life-threatening operation to make them live longer. Other patients have really bad symptoms of breathlessness and chest pain, and it's more obvious to them that they're coming in for an operation, and they will accept the risks to get rid of those symptoms. But those are a particular cohort of patients which are different to patients who come in as emergencies. And those patients have bad diseases, acute diseases, which are life-threatening, and suddenly out of the blue, something has happened to them on any given day, and they come in for an emergency operation, and they are going to die without an operation. And so effectively, those patients have no choice. And I think as a surgeon and as a team, you may feel that all you can do is good in that situation. And if it doesn't work out, then it is sad, and you'll still reflect on how you manage things. But that's a different circumstance, those two groups of patients. I guess, like you say, it's interesting that the perception that some patients or family have about the risks of heart surgery. So quite often when you see patients in the clinic and you say, well, your risk of dying from this operation is 3 or 4%, or your chances of survival are 97, 98%, they're very happy with that. And sometimes we tell patients that they're going to have high-risk surgery, which may be 10 or 20% risk of survival. But quite often in the lay public's mind, heart surgery is still 50-50, whether you're going to come through it, whether it's elective or emergency. So quite often the risks that we perceive as high risk are not the same as what patients perceive as high risk. So it's not often that a patient will die in the operating room. It does happen, and it happens to probably every surgeon a couple of times a year. And those are particularly difficult things to deal with, because usually either the patient has come in extremis and really at death's door, and you do all you can, or there's been some difficulty in the operation, possibly a technical issue, possibly something that could have been different with different decision making. And those, although they're rare, those hit the team the hardest. And having a patient die on the table at the end of an operation is very difficult. Mostly the deaths that we face are patients that we have got through surgery and then they go to intensive care. A typical patient would just spend one night on intensive care and go to a normal ward afterwards. Some patients spend weeks, some patients spend months and have a tracheostomy in their windpipe to help them breathe, and they may end up with other organ support like dialysis, things like that. And those patients may die many weeks or months down the line of a complication such as a stroke or some issue with the bowels or the liver or kidneys. And so quite often with those patients, there's a lot of warning, and there's an expectation that things are going in a particular direction. And sometimes there's time to talk to the patient about what's going on, but often it's a conversation with the relatives. And then I guess the third group is a patient who's gone through ITU, through the intensive care unit, and no particular issues, and they've gone to a normal ward, and they usually stay in the hospital for about a week recuperating. And then maybe once or twice a month in a unit of Liverpool size, there will be somebody who has a sudden cardiac arrest on the ward and dies. And again, those are difficult to take, because the patient survived the operation, got through intensive care, gone to the ward, is really just sort of waiting to go home. And then it seems even more of a tragedy that they were so close. So I guess the circumstances of the patient presentation and the circumstances of the surgery and the circumstances of the post-operative period all impact on how deeply a surgeon and the team, because I must emphasize that it's the team, everyone's impacted by it, but it impacts differently. And as I said before, I think from a patient or a relative's perspective, whatever happened to the patient's happened, and their relative has died, and the circumstances may not be that important to them as it is to the surgical team. So yeah, it's very different.
You mentioned that you might have to go through this a couple of times a year, maybe on the table. So it follows that there must be somebody somewhere keeping a close eye on the stats and when people die and how they die and how often they die. So how is success measured in your job? Because I'm guessing on paper it's very different from what you're actually making decisions for in real life. How does that work?
So yes, this is a difficult one because it's important that surgeons are monitored in all specialties, and so that as we've all seen on the media, that some rogue doctors, rogue surgeons, and it's important that the patients are kept safe from such deviations in activity or performance. And in heart surgery, it's easier than probably any other surgical specialty to measure quality, because the frequency with which patients die following heart surgery means that the performance measure for a heart surgeon is the number of patients who die. So over a 3-year period, we're monitored nationally, and it's a very stark but simple graph that they present to us, which is essentially the number of patients which you've operated on over that 3-year period versus the number of patients who've died. And that's quite stark, and you can't argue with that as an endpoint, because other endpoints such as quality of life you can argue with, but for a cardiac surgeon, you really can't argue against measuring death, because it's obviously just black and white and it's not something to be interpreted. And there are some scores that allow for risk. So if I operate on very complex patients, those patients will be scored according to their age and other things, and I will have a certain allowance for that in how they measure my performance. But if after a 3-year cycle it's found that my mortality, as we call it, is more than a certain percentage, then I will be challenged by the medical director of my hospital, and then I'll be challenged by our society who monitor performance. And so that is difficult because it does affect the way you behave. And although as a doctor you want to give every patient the best chance and the best option, and you want to be consistent in that, it can be difficult because we're all human. And if somebody's measuring your outcomes and you're in a situation where your outcomes are borderline, difficult to separate that in your head, but you have to at the end of the day. But it's difficult because once you become sort of performance managed, as we call it, then I guess it's a source of professional embarrassment that you're being performance managed. It has an impact on everything in your life, because that is what you've trained to do this job for 20 odd years. You've been practicing for 10 or 20 years, and there is a risk that you may lose your job and your livelihood, and there's not much else you can do. Highly trained cardiac surgeons don't really have much else to do. But that affects, that just it clouds your mind a little bit. But you have to very consciously think, I'm making decisions based on what I think is right and what I think is wrong and what my opinion is. And so performance management comes with a package of measures, and it comes with that you're told that you may have to operate with another surgeon, so for safety, or you may have to only do patients with a certain risk profile. And there are various other supportive sort of wraparound things that are put in place. So you hope that it doesn't affect the patient outcome, and that's keeping patients safe. And so, all these measures are designed to keep patients safe. And it all came out of the Bristol Children's Inquiry that went on some decades ago now, where perhaps the mortality was higher than expected for a certain operation. And that led on to measuring surgical performance. But you would hope that measuring performance keeps patients safe. On the other hand, on the other side of it, you need to be careful that it doesn't prevent patients from having an opportunity. And it's important for us as leaders that if you have a surgeon that's in difficulty and has been performance managed, that the temptation, I guess, may be to not offer patients high-risk operation. And those are the patients that actually will benefit most from it. So it's for us as an institution as leaders to take that away from them, let the more senior surgeons or the surgeons with better outcomes manage those patients. And in the end, the patients and relatives don't suffer from that, and the institution manages that risk. So it's really a balance. They do measure us, but it's a balance between keeping patients safe and giving patients opportunity, and not letting all those things cloud your judgment in what you do. It's difficult, and it's probably, I don't think it's like that for any other surgical specialty, because it's not so black and white in terms of measuring outcomes.
Yeah, I can see how that would be difficult just by, human nature and just normal workplaces. You can see how there would be some people who would naturally think, well, I'm not going to take on any high risk cases because that's going to affect my stats. And then you can see other people who would be like, well, I want the high risk cases because actually that's where the interest is for me. That's where the opportunity is. That's where I could potentially do something amazing. But if I only take on those kinds of cases, then I'm risking my stats being bad. So yeah, I can see how that would be really difficult to balance.
Our last society president was Richard Page, who was a thoracic surgeon actually, but I think he had the insight and the foresight to see that patients were perhaps losing out because of the way we measure things, and so he introduced a system where it's called a NICOR exclusion. Essentially, it means that if you have a very high risk patient who is going to die without an operation within a couple of weeks and not an emergency, emergencies are excluded from all these measurements, which is good. But if you have a patient that needs a third or a fourth time operation and infection, and the risks are very high, we can go to an MDT, a multidisciplinary team meeting, and providing that the surgeons all agree that this should be excluded from the statistics, then you can have an exclusion. It's a great benefit. It means that 2 surgeons are mandated to scrub and operate. So you've got 2 senior surgeons at the table doing the case, and that doesn't count on anyone's statistics, as it were. So it tries to prevent all those things coming in to stop patients having opportunity.
Oh, that's really good. And I'm guessing, going into something like this where someone's going to die one day, you probably didn't come into this thinking I'm going to be the first cardiac surgeon that's never going to have a death. What happens when you have that first death? Do you remember that first death, and are you prepared in your training for that?
So I guess, and I haven't been to medical school for some time, just acknowledging my age, so things may have changed a little bit. But when I went to medical school, there was no training around how you manage a patient dying. And I think it's obviously probably different for different doctors because of the level of investment. Possibly, maybe, if a GP, say, has a patient in the community in a care home that dies, and they may have seen once or twice over a period of 10 years, that may have a different impact to a surgeon that it's just one single patient that you have done something to. And so I guess in medical school, they never really taught us, because I guess medical school is general training. But certainly where I went to medical school, they never taught us about or gave us any tools for managing a patient who dies, or how to process it, and how to reflect, and how to be able to continue practicing after a patient dies. I guess, I mean, I know, over the course of my career, there are probably had 30 patients who have died, and I'm not sure if it's a morbid thing, but I'm sure every surgeon is the same, because every cardiac surgeon keeps a very close eye on their own data and their own outcomes. And so I have a list of patients who have died, and every single one of them, I can look at their names and remember every single detail about what happened. And I guess partly, that's personally for me to reflect on whether I could have done something different, whether the decisions that were made could have been different, and I guess every death that happens in any hospital, and particularly in cardiac surgery, gets a review called a mortality review. And so your case gets scrutinized by another doctor, surgeon, or anaesthetist, and it's rated as avoidable or unavoidable, and you get various feedbacks. And if there are particular issues, then it's discussed on an audit day, where all sort of the hospital are in a theatre, in a lecture theatre, and there's open discussion. Sometimes, obviously, that can be difficult. Sometimes you have to take criticism. Sometimes you have to accept that you could have done things differently. Perhaps the outcome would have been different. Quite often, it's grey, really. It's never really, very rarely is it clear cut that there's been a technical issue, or there's been something you made a bad decision on. It's usually much more grey, thankfully. But yeah, there isn't a lot of preparation for it. And in terms of how it's managed, I've seen, as a junior doctor, I've seen it managed very well. I've seen it managed very very poorly. And when I say that, I mean about personally how you process that information. I remember particularly vividly one consultant surgeon who patient had a cardiac arrest following a heart operation on the following day. And as it is with cardiac surgery, once if a patient has a cardiac arrest after they've had an operation, then usually it ends in the chest being reopened to make sure there's not a collection of blood around the heart that can easily be fixed. And quite often, sometimes that can be on a normal ward, which is quite extreme. Sometimes it's in an intensive care. But I remember vividly watching a patient chest being reopened, and the consultant surgeon had done the operation the day before, appearing and did all he could. There was no obvious cause as to why the patient had a cardiac arrest, but the patient did die in intensive care. And I remember that surgeon crying. And I can remember tears rolling down his eyes. And at the time, I didn't really understand it. And I have to be honest, because I was a surgical trainee, and you don't really have as much insight, or you don't have as much understanding of the personal investment you have when you operate on someone. And so I was a little bit dismissive, and I just thought, why would he cry? Why would he cry in front of the whole team? Like, I remember, but I always regretted, once I became a consultant, I always regretted that, because I personally have had many occasions where it's happened to me. And, tears come to your eyes, either at the operating table or wherever you are on the ward, or when you're speaking to relatives, because it can be very, very difficult, just the rawness of the emotion speaking to relatives. And it's just about how you process that, what's just happened, and how you gather your thoughts, and how you manage yourself, the team, the family, and then how you come in the next day. And so quite often you just have to muddle your way through. And from my observation of younger surgeons coming through the system, I don't especially think they've been trained in a different way to manage these things, because it's just hugely, hugely personal. When, you've seen a patient in a clinic, you've talked to them, you've chatted with their family, you know them, you've agreed to do an operation. The expectation is they're going to get through the operation. And so it's a massive investment. It's a bond between two humans, I guess. And then when it goes wrong, it just leaves you with a massive sense of you failed that patient. And sometimes you genuinely feel you have, and on other occasions it's just circumstance and the disease that has just been too extreme, and you haven't been able to, and probably no one, no surgeon anywhere would have been able to get that patient through. And but it's trying to process all that information to try and understand what's happened, how it happened, whether there was any learning or reflection, anything you can share, anything. And then managing the family, but then going on. And then quite often you may have an operating list the next day. That's difficult. But I mean, and I'm hoping something like this may help patients and relatives, and hopefully other professionals as well, because mostly we don't talk about these things. And as I've said to you before, I've had some hesitancy in talking about this on your podcast, because mostly surgeons do not talk about these things. It's in sort of unspoken truth, I would say.
There seems to be this assumption with a few different areas of work where we've spoken to people who deal with death, especially on a daily or weekly basis, like whether it's murder detectives or paediatric intensive care nurse we spoke to, or funeral directors. There's this assumption that you're a certain kind of person that can deal with that kind of thing a lot easier than other people, which is a shame, because it's got nothing to do really with a human dealing with death and dealing with loss. It's all about your skill sets, and you've got skill sets in all these different areas, but that doesn't mean you're any hardened off when it comes to dealing with loss and grief and relatives of people. And it was similar when we spoke to the funeral directors. They said, people They don't really talk about it much, and they admitted we've got PTSD from some of the stuff we've seen. It doesn't mean we're any stronger at dealing with these things, and that does seem to be a shame because it doesn't impact the training that you go through. And I think you're probably right in assuming the training hasn't got a lot better in helping people deal with that side of it. How do you deal with the grief and the loss? It's a bit more sort of technical and education based, and this is what happens. And maybe here's some practical steps. Maybe you need a debrief. Maybe you need to talk to someone else. Maybe you need some counselling. But there isn't that kind of maybe setting people up for saying, you know what, you're human. You might cry when one of your patient dies, and that's okay. You might need a week to reflect on it at home, or it might impact your personal life. That's okay. You're human. And I think that would help a lot of people. And I think that's why this is an important conversation, because I want other people in these sorts of professions to hear it, that it's okay if you struggle with human emotions connected to your job. And I know you've mentioned there are a lot of different human emotions when it comes to surgeons and responses to stuff, and they vary a lot. What are the sort of different ones you've seen, and what's your go-to? Are you a kind of do you get angry? Do you get upset?
So I've seen a range of things. And it depends on people's personalities, and there's a classic range of responses. I mean, some people get very surgeons, I would say, can get very angry. They get very cross. They start shouting. They're frustrated. Things are not happening, and they have a life in front of them which is slipping away. And it's understandable that if the team around them aren't doing things before they're even asked, then they get frustrated and start shouting. That's probably the worst response, because what you need in that circumstance is you need your team. You need help. You need an anaesthetist who's supportive. You need a perfusionist, the person who runs the heart-lung machine, to be supportive. You need everyone to be on their A game at that moment. And quite often, you need surgeons to come into your theatre and to look at things afresh and offer advice. And so at that moment, you need your team around you if you're going to get the patient through, and you need to work through the problems and forget about everything else. It doesn't always happen. Other people go completely introvert. And I guess that's me. I would say my anaesthetist would tell you, I have been a lifelong project for my anaesthetist, Justin, who I think has worked on me to try and get me to communicate during those episodes. Because in my mind, when I get into those situations, and it's wrong, but you can't see light or day in those circumstances. But in my mind, the only way to get this patient through is something surgical. And in my mind, the only person who can do that is me. And it's wrong. But in that moment, it's all going through my head. And it's, what are my options? Sometimes doing something can make things worse. Sometimes you can get a patient out of the operating room alive, but perhaps in some way harmed. By that, I mean, possibly a heart attack during the operation. But you can get the patient out alive, and you can live to fight another day, as it were. And if there's something you haven't done, or something in terms of operation that you're leaving in terms of the disease, it's a decision. Shall I accept the situation I'm in, get the patient out of theatre alive, and then come back to theatre down the line to address that issue? Or can I not get this patient out of theatre and I have to do something? But doing something you may lose that position you're in, and it may be a worse position. And in my mind, in that moment, it's just a decision for me. And so I just go quiet. And I think normally we have music playing. So usually I ask for the music to go off. That's when usually people know something's wrong. And then I stop talking, because usually we're talking a bit. And then I think everyone thinks, Mark's gone quiet, something's wrong. And then usually Justin will sort of go, okay, what's the problem? And then we'll try and work through it together. Another surgeon who used to play music, I remember one of the surgeons who trained me, he used to turn up the music when things were happening. I don't know if that was to drown out the bad thoughts or not, but mostly I would say people are in the middle. So people, yes, they get a bit frustrated because things aren't happening quickly. They go a bit quiet because they are actually thinking about what all the problems are. But then they're able to dispassionately, and I think those are probably the surgeons who handle it best. They're actually very matter of fact, and they go, okay, I've done this, it didn't work. I've got options A, B, C, D, E. What are we going to do? And then there's a discussion, and then it happens. And from the outside, on the face of it, you may think, well, that person doesn't really seem to care. They're not shouting, they've not gone quiet. They really seem completely detached from the whole situation. They've just got some options, and you may look at that and go, well, they didn't really seem to care what the outcome is here. But I think that's misunderstanding what's going on. I think those are probably managing the situation best, and then managing it objectively. And then all the other issues that cloud your head around the death, that surgeon will process on another day, I think. So yeah, there is a huge range and room for improvement for all of us, I think. Yeah.
And ultimately, when someone's operating on your heart, you don't really want them. Well, I don't know if people think about this. I wouldn't want them thinking about, the situation of, oh, this is a young mum with 3 kids and what am I going to do? And, all those sorts of things. Bringing in the actual personal circumstances of that person is not going to help you. It's just going to cloud things and make it more emotional. So ultimately, you do want somebody that's not really... Well, yeah. They're caring, but like you said, it probably looks like they're not caring. But you kind of want them to be able to compartmentalise all that for the right time, because there must be a lot of other things there you're having to deal with. There must be some fear that starts to come in at this point. And I know I've heard you talk about how that fear helps you focus the mind, but sometimes it can be misconstrued as arrogance in your profession. And I can see how that would happen. Do you find that hard? Do you have to try and convince people in any way that you're not arrogant and that you do care at times, or do you just have to let that go, what other people might think, and just get on with your job?
Yeah, I think you'd have to let it go. People around you know who you are, and you can't hide it. I mean, one thing about this specialty is you can't hide your personality, because you're quite often functioning in the extremes of a situation where you can't control the narrative about who you are and what you are. And so people, over a course of many years, because obviously we're a close-knit team and there isn't a huge turnover of staff, and so we all know each other. We socialize a lot together, and so you can't hide that aspect of yourself. And the team around you generally know who you are, know what support you need. They know your skill set, and they know what you can do, what you can't do. They'll know how you're going to react, and quite often the anaesthetist is pivotal in that, because the anaesthetist, even though the surgeon may be in denial and go, I don't need any help, I'll sort this out, I'm fine, the anaesthetist will obviously be on their phone texting a friend, so-and-so's got a problem, can you come into theatre? And even though you may not think that you need help, someone will appear. And it's usually because someone has texted someone to say, so there's a problem here. And we have a very supportive hospital, and it's not the same in every hospital, I would say, but certainly in Liverpool, once you have a problem, 2 or 3 surgeons will appear in your theatre, and that's really important that there are a couple of people. Because, as you say, quite often these patients well, and you've met the family, and it is hard if the patient has 3 children, and you've met the children. Sometimes I think it's difficult to meet the children of someone you're going to operate on, because it's nice, but it also affects you, and it makes it very difficult to be objective and to be dispassionate and to do what you need to do. Because you're right, when you see something going wrong in front of you, your thoughts will automatically go to, well, he can't die. He's got, or she, they've got 3 children, and they've got this and they've got that, and there's all this history, and then that feeds into clouding up all the issues and making it difficult. Like you say, the best thing is to compartmentalize everything and just work through the problem and get the patient out, and then speak to the relatives along the way. Even though we're cardiac surgeons, we are human, and people, I think, sometimes forget that, but it does affect us enormously. Even surgeons who it may appear are not connected or in some way detached from it all. Often it's just their way of processing the tragedy.
What have you sort of seen when it comes to things like coping strategies? Because, again, speaking to different kind of areas of work, like the police, they've got quite a dark sense of humour. That's part of how they cope with a lot of what they see. For other industries, they're quite famous for maybe people drinking too much or getting into other addictions that are very unhealthy. Have you seen good coping strategies in your line of work? I feel like I want to assume that you haven't. I don't know why. I don't know if it's because my mum was a theatre nurse. Just having seen bits and bobs and heard them talking, and I don't feel like the medical world is brilliant with great coping strategies for how to deal with what they deal with. But that might be a huge generalisation I've got wrong.
No, I think you're absolutely right. I mean, I don't think anyone has specific coping strategies. I mean, there are issues around your performance, which we discussed, and those are all managed and, hopefully managed well. But, and then maybe if you have a run of deaths in a short period of time, I guess I can't say that I've ever seen or heard about a sort of surgeon, taking to substance misuse or anything like that to cope. I've seen them become a bit withdrawn, and I've seen them become detached from the department. I've seen them, start to become accusatory, maybe perhaps a little bit paranoid. All human traits, but more acute when you're in a situation where you need to keep working, and you need to be convinced that the reason 1 or 2 or 3 patients died is not because of you or anything you've done. You need to rationalize it in your mind and come to some decision whether you think this is something you've done wrong and you need some retraining or some support, or whether you think, no, this is just 3 things that have happened in short space of time. But I just hesitate because I don't think I've seen a surgeon go off the rails, as it were. I think there is that support there, particularly I think in Liverpool anyway. We have an early warning system. It means that we will intervene. There are various points that the national body may intervene on your performance, but in our hospital we try to trigger that sooner so that we can correct things before it becomes a national issue. I mean, I didn't mention it, but your outcomes, as it were, are published in the internet. Like you can log into the society and you can see what my outcomes are. There's no hiding from that. So hopefully things are corrected in Liverpool, certainly before you get to that point. And so I guess when you ask about coping strategies, a lot of it is very personal. A lot of it is hidden away. You may get some hint of it. A surgeon may say, well, I've had a death today. I'd rather not do the list for tomorrow. I'd rather not operate for the rest of the week. Or can I not do this case because I just don't feel up to it? And those are subtle things that that someone isn't coping that well with what's going on, and so they're just asking for a bit of space. But apart from that, I don't have a good answer for you other than you're right. So it's probably not well managed. There are no good strategies, and it's sort of hidden away, and people are left in a dark room, as it were, to cope with whatever they need to cope with and then come back when they're ready.
So you obviously deal with the losses of life and death, but are there other losses that come with a job like this that maybe other people aren't aware of, other kind of secondary losses maybe, or things that you've faced or others have faced around you?
Absolutely. And as we talked about earlier, patients dying are actually quite rare. They're obviously traumatic when they happen, but overall, heart surgery is quite safe. Mostly what happens are the complications, and that is quite often a form of loss. Because it's a loss of quality of life, and sometimes it can be a loss of function. So one of the main issues, although we operate on the heart, the main issues are around the brain, are around the spinal cord, or around other organs in the body, the lungs, the kidneys, the bowel, the liver. And so cardiac surgery is quite unique in that although we're very focused on fixing the heart, to fix the heart you have to stop it mostly, not always, but mostly you have to stop the heart. And it's the heart-lung machine that you connect to the patient, and that will keep the patient alive while you stop the heart. The consequence of that is that you will affect lots of the other organs of the body, and that's why these patients go to intensive care afterwards. Mostly sometimes it's for support of their heart with various drugs and various devices, but also it's to support their kidneys, support their liver, their bowel, their brain, spinal cord, all the other organs of the body. So quite often, when we talked about patients dying down the line after a couple of weeks on intensive care, it's quite often as to what we call multi-organ support or multi-organ failure. And so other organs start to shut down and other things are required to try and support them. And so it's the complications of operating on the heart that lead to loss. And one of the biggest issues is of stroke. It can be very, very hard to go and see a patient post-operatively on day one, because quite often they're kept asleep for a few hours and then they're woken up and they're taken off the ventilator and then they're awake, and then surgeon traditionally comes around in the morning on a ward round to see the patient, and then you go and speak to the patient and they can't move one side of their body. because they've had a stroke. Sometimes patients with particular operations can get paraplegia and they can't move their legs. And these are permanent things, paraplegia. If it's there, it doesn't get better. Stroke can get better. Sometimes it doesn't. But you feel personally responsible again in those circumstances. Could I have done the operation in a different way such that they wouldn't have had a stroke? And it's a devastating thing because they just look at you from their bed and they can't move their arm or their leg. And they're like, what to do now? And there is very little you can do apart from get them into stroke rehabilitation and get as much function back as you can. But I think for cardiac surgeons, it's stroke that is the biggest thing, really, because it's much more common than death. It really affects their quality of life, and it affects the outcome of the whole operation. I remember one patient in particular who was in his 80s, and he was quite fit and active. He loved his garden. He had a huge garden, but he had this big aortic aneurysm, which is the aorta is the main blood vessel that comes out of the heart. And it was quite big, about 7 centimeters from memory. Normally we would operate when they're about 5.5 just to prevent them rupturing. So he was in his 80s, and the suggestion was that he should have an operation to get rid of this aneurysm. He had no symptoms from it. Patients have this idea it's a ticking time bomb, then it's going to rupture. And he couldn't really live with that knowledge that he had this aneurysm in his body that could just rupture at any time. He decided he wanted to have an operation. And I think between us, we met each other a couple of times, and I had some reservations. The patients in their 80s, the outcomes are difficult for heart surgery. You have to be very clear that you're doing the right thing for the right reasons. I mean, someone's in their 80s. And essentially, this was an operation to make him live longer, or to treat some of the issues he had with psychologically coping with the knowledge he had this aneurysm. The average life expectancy in the UK maybe around 83. And so doing an operation on someone at 83 to make them live longer, it doesn't make a whole lot of sense unless there are good reasons, and he just couldn't live with this. So we took him to theatre, and the operation went perfectly well, and came in to see him in the morning, and he'd had a stroke and he couldn't move his left side. And you just think, gosh, I always remember that patient because he had a good quality of life. He was in his garden. He had an operation to make him live longer. Yes, he may live longer, but he's lost his quality of life. He did make a good recovery, actually. In the end, he went back to driving. I mean, he wasn't perfectly normal again, but he's sort of one of those patients that affects you during your whole career in terms of decision making. And whenever I come across an octogenarian and the proposal is that they're going to have an operation, then I always think back to that particular patient. Think, really, is this the right thing to do? And those are the sort of difficult decisions that you have to live with. It's definitely a form of loss, and it's quite often with the type of operations we do, which are very large, there is a trade-off sometimes between you're doing an operation to make someone live longer, particularly in a younger age group, in the 50s and 60s. You can do an operation to make them live longer for prognosis, but the operation is so large that they never fully recover from it. So they lose some of their long-term quality of life in exchange for prognosis for living longer. You never quite know what that trade-off is. Since COVID, we have this term new normal, and I think that in some of the operations that we do that are so huge, that is a real thing that yes, we can do this operation to get rid of your aneurysm that will make you live longer, but in return, you're going to lose some of the great quality of life that you have. And those are very difficult conversations.
Yeah, and again, do you get any preparation or training to have conversations like that? Because I'm guessing there's times when you have to tell people someone's died as well. I'm guessing it depends on at what stage they died, as maybe who's involved there, but you're facing a lot of very raw grief, even if it was, that people thought, well, it might be a little bit expected, you're still facing that initial response. And those sorts of skills for those sorts of conversations almost couldn't be further away from the technical surgery that you're doing on the other side. So do you get help with how to do that?
No. There's a theme here. But it's very, I can tell you, it is very traumatic to go and tell someone that their relative has died. It is very traumatic. Some of the reactions are so visceral. I remember, again, I just go back to my training because I remember a particular example of where it was done really, really poorly, and that a patient had died following surgery, and the surgeon sort of appeared and he had his backpack on, jeans, and sort of push the relative's room, the door open, and sort of say, well, I'm sorry, your father's died, and there's nothing I could do. And then, almost immediately just left them with a nurse. And I remember thinking at the time that was just, probably he'd had no training in it, or no guidance or how to do it well. And it just always stuck with me. That was so bad, in terms of how you can go and speak to relatives. Cardiac surgery is a little bit unique in that quite often you have warning. Even when a patient is going to die on the table in the operating room, the heart-lung machine will keep them alive. And it may keep them alive while you're trying to fix things, but deep down you know that there is a problem that you may not be able to get out of. And quite often we know in intensive care, patients are kept alive artificially. So quite often there is some warning of things. But families, just like surgeons, react differently. Although we only have to go and speak to families, probably most 5 times a year to give them that news, it can be extremely traumatic. And I guess it depends on the family dynamics and how close the relatives are and all those human things. And sometimes it's quite sort of, just like some surgeons, a bit detached, and because people react differently and they may not react in that moment. They may go away and react later on down the line. But in some, you can witness the relative crumbling in front of you, and they may be sort of shouting and screaming, and people may run out of the room. And sometimes it can be quite aggressive as well, because they may think you're personally responsible. And sometimes the response is so deep and so visceral that it's almost shocking to you, and you're almost like you just don't know what to do. You definitely need a mechanism to manage that situation. You need some sort of tools, which unfortunately you learn through experience, some sort of tools as to how to prepare, or to have the thought to prepare someone for that, if you have time, and in some way impart that information. And I've seen, again, just another example, I've seen a doctor when I was a junior watching, and the doctor spent about 15 minutes going through what had happened, and in the end stopped and looked at the relatives, and then the relatives sort of said, well, is he dead?
Oh no.
And it's like the doctors tried to go through the pathway, tried to explain it all, but not got the key information out at the front. So that's certainly one thing I've learned, is that you can't go in and blurt out they're dead, but you need to get to that point very quickly. It's a matter of, look, I'm really sorry, we've tried everything with them, but they've not survived. And you need to get that thing out really quickly, and you need to be very clear about it. You can't leave any ambiguity there. There will be questions, and they may have questions immediately, but those questions, even if you give the answers, they're probably not going to take it in. Another thing I've learned is to write to them. I think it's really important that as a surgeon, you write to the relatives in a couple of weeks and just offer them an open appointment to come whenever they like, at any point in the future. And quite often, some relatives will take you up on that, and they'll come to clinic or to see you in sometimes 6 months, when they've had time to process it and they've got questions. Some people will find it very traumatic and never want to come into the hospital again and can't really face it. Some people will be happy to do it on Teams, and some people will come in face to face, and their entire family as well. And sometimes that can be a rewarding experience. You can explain to them. Quite often relatives may not know how poorly the patient was, or they may not have understood the risks of the operation or what exactly had happened, because sometimes patients will just not really tell their family what the risks are and try to hide it from them. And sometimes those meetings are played out in the coroner's court, and it's difficult, but there is no training for it. You learn through observing it being done badly and it being done well, and through learning what works for you, because everyone is very different in terms of in that moment. It's one of those things like we discussed earlier. You may think that the more of it that happens, the better you get at it, but probably the more of it that happens, you just become more traumatized by it, and you don't get better at it, really. It's just cumulative trauma that you need to somehow process or channel away in a different way. I don't think you can ever get used to it, or you don't want to become good at it in a way, but you never desensitize to it. Because all the time, just human nature again is that you reflect on your own family and how would you react if you were in that situation. So and all the investment you've had with the patient and the family, it becomes very personal. So it's really very, very difficult. But it's definitely something I would suggest is never delegated to a junior doctor. Take one along with you so that they can see, but never delegate it. And you should always find, all nurses are compassionate, but you should find especially compassionate nurse to go with you, because surgeons are surgeons and they can do what they can. Some are good at it, some are not so good at it. Some may have more of a human touch than others. But one thing that I've found consistently is that the nurse that you take along, quite often, it's the correct thing to say, but quite often they just have more of a human touch. They have more ability to relate. And then quite often when the news has been given, the surgeon can leave, and usually the nurse will stay and do all those other things that are important in managing what's going on.
They've got that bedside manner that surgeons sometimes lack. Yeah, and hopefully that's really encouraging to people that are, sort of behind you earlier in their career, that are really struggling with doing those first few and thinking, oh my word, is this me? Am I not cut out for this? Why can't I do this part of the job? To hear that you still struggle with that, and it's something you never really get used to, but that's okay, because there are other people that you can put around you to help with that. I think that's really important for people to know. One of the questions we ask all our guests is around the question why, just to find out, is that something that people battled with? Have you ever questioned why you got into this kind of work, or why you're doing this, or has that never really been something that you've thought about?
I mean, I think to me it's clear, like actually it's an extremely rewarding specialty. And as I say, mostly these things don't happen. 97, 98% of the time, the outcomes are excellent. And, you meet up with a patient at a particular point of their life. They've suddenly got heart disease. They think they're going to die. Usually they're convinced they're going to die. And you are able to offer them options to treatment, and then agree with them, and then take them to theatre and fix their heart. And from a technical point of view, that's an amazing thing to do, as we discussed. It's an amazing thing to be allowed to take someone to an operating room and open their chest and fix their heart. That is an amazing thing on a daily basis. And then it's very rewarding because, those patients, you meet them post-operatively and you meet them in clinic, and some of them quite often in the type of operations I do in aortic surgery, they need repeat interventions over the course of their lifetime, and you get to know them, you get to know their families, and so it's extremely rewarding technically, and it's extremely rewarding on a personal perspective in the relationship you have with these patients and how you're able to help them. And I think I can't think, when I think, what if I hadn't done cardiac surgery, what would I have done? I mean, the answer I often give my children is I would have been a farmer. I can't think of any other medical specialty that would give me what I get. And if I wasn't going to be doing this, then I'd happily chase a few pigs around the farm.
So I guess, where you're talking, people place so much hope in you. They come to you with the hope that you can make somebody better or you can keep them alive, which is quite a pressure in a lot of ways. But there's obviously a lot of hope in other ways, because like you said, the statistics are really good for what you do. So are there any other ways that hope plays a part in what you do?
Well, I often have this banter with my anaesthetists because I sort of have a bit of an academic background. I often say, everything I do is based on science and research, and they just cough and laugh at me because most of it's pseudoscience and it's not based on any science at all. So, I mean, it's not quite at the stage where we keep our fingers crossed and hope for the best. But there is hope in all aspects of it, I guess. There is hope that you can, from the patient perspective, that something can be done for them. There's hope from a surgeon's perspective that you can do something for them. The outcomes, are, as we've discussed, can be along a broad range of things, from success to failure. And some of those things you can control as much as you can. And the more experienced you are, the more things you can control, because you can stop yourself getting into trouble rather than trying to get yourself out of trouble. And it's not just about delegating or just imparting that information so you can say, I told them. It's also about giving them some hope and saying to them, look, this is the situation. It really doesn't look that good. However, there are certain things we can try, certain things we can do. We're going to do that and see if we can change things around. However, we may not be able to. It gives them some time to think. It gives them some time to process and gives them some hope. But yes, there is hope. Every day I drive into work to do an operation. I mean, I do still imagine myself driving home at the end of the day, and I don't know what the outcome is going to be. I often think, I really, really, really hope that I'm driving home reflecting on every single aspect of the operation and how well it went and how the patient's done so well, and that's like so pleasing. Sometimes you can't really sleep that night. You just you're just focused on replaying the operation, and then when the patient does well, you're so happy with the outcome. And other times it's not like that, and you're driving home thinking, what the hell just happened? And you wake up the following day going, was it a dream? Was it a nightmare? No, it's real, it happened, and having to live with what happened. And so when you go to work, definitely there is hope that the outcome is going to be good from the surgeon and the patient and the family. And there's hope as well, I guess, in the team, because the team, we've not talked much about the team, but the team are really important, and they're all obviously humans as well, and they all like to work with successful surgeons and in operating theatres where the outcome is good, because when it's not good, it's so traumatic for everybody. There is hope from everyone at every point in the pathway that things are going to go well, and mostly they do go well.
Okay, so our last question is, what's your Herman? Which is what things would you want to gift to others to kind of help them in these kinds of situations? And I know with the scientific brain, this is a bit trickier for you. So, looking back over everything you've done and, everything you've accumulated, what sort of things would you want to share with others about what you do? So what's your Herman?
So I thought a lot about this, tried to understand it and tried to come up with a good answer. And I think it is around how we manage death, but not around the patient. A patient dying is a tragedy for everyone. But one thing that I've learned is that if you manage that death badly, you can affect the quality of the life of the entire family for a generation. If you manage it incorrectly, there can be so much bitterness and so much resentment in the family for their entire lives. And it's so important to get that right and to avoid not just the patient dying, but in a way the family dying, or the family suffering that loss for an entire generation. So if I was to give advice to someone coming behind me, it was, yes, the death is tragic and there'll be all sorts of things and issues to cope with around that, but your focus has to be on the family. Certainly if it's during an operation and you have an opportunity to get out when you know things are going wrong, then go and speak to the relatives. Or if it's on the intensive care or the ward, then speak to relatives, give them forewarning, but also give them some hope. I think hope is really important.
I've heard it said that if you have nothing to be grateful for, check your pulse. And I suspect this has an extra special meaning for those who have survived life-saving surgery at the hands of surgeons like Mark. So thank you to all surgeons who are taking on the risks and duties of dealing with human lives every day. I'm sure you don't get half the thanks you deserve, all that are probably said behind your backs.
And a big thank you to Mark for being willing to venture into a subject that other surgical professionals might not know how to broach. It's such a brilliant and insightful conversation that we know will help many others in similar vocations know that they're not alone in having to handle loss and grief on a regular basis. And of course, it's okay to not find it easy. To hear more of our episodes into other careers, visit our website, thesilentwhy.com/let's chat.
Yep, on that page I've got a list of all the conversations we've had with people who have jobs that involve working with death and grief on a regular basis. This includes a Scotland Yard murder detective, who's everywhere at the moment, he's even on TV, a paediatric intensive care nurse, funeral directors, police chaplains, funeral celebrants, an end-of-life coach, and many more.
And for more on Claire and myself, visit thesilentwhy.com or follow us on social media at The Silent Why Pod. For more about Herman, you can go to thehermancompany.com or follow him on Instagram at The Herman Company. He's even been travelling recently.
If you know someone that just needs a boost at the moment, maybe they're going through hospital treatments, chemo, exams, grief, loss, or a tough time, why not send them a Herman? He's the perfect handmade by me companion to help people know they're not alone in whatever tough situation they're going through. If you have no idea what we're talking about when we mention a Herman, just head over to the website in the show notes. UK shipping is free, but I can ship him anywhere in the world for you. I know that you know somebody right now that just needs a smile.
We're finishing this episode with a quote from Christian Barnard, who is a South African cardiac surgeon who performed the world's first human-to-human heart transplant.
I realised all of a sudden that life is the joy of living. That is what it is. It is really a celebration of being alive. You see, what they taught me was that it's not what you've lost that's important. It's what you have left that's important. But I qualify this. There must be a joy in living. There must be still enough left so there can be a celebration. You can't celebrate nothing. There must be something to celebrate. So I think one must realise that as a doctor, if you value life, your goal must not be to prolong life. Your goal must be always to provide something for that patient that he can celebrate. Provide something so that life can be the joy of living.